Good morning, good afternoon, and good evening to everyone joining us from around the world. My name is Philippa Mbonye, and I currently serve as the EPIC Secretariat. I'm delighted to welcome you all to today's webinar on how to use AI responsibly in healthcare. Thank you for taking the time to join us and to join what promises to be a very timely and thought-provoking discussion. Before we begin, I'd like to take this opportunity to introduce EPIC to those of you that are joining us or hearing from us for the first time. EPIC stands for Ethical Principles in Healthcare. It was established by the World Bank Group and IFC in 2019 and is a global network of over 455 member organizations committed to promoting ethical, patient-centered healthcare practices. So through collaboration, knowledge sharing, and collective action, EPIC seeks to strengthen trust, integrity, and quality across healthcare systems worldwide. We invite your organization to join this growing global movement, and our team will share the website link in the chat for more information and to get involved. The importance of EPIC's mission has never been greater. In a rapidly evolving world of technological change, it is essential to ensure that healthcare remains equitable, transparent, safe, and centered on patient well-being. So this is why today's topic is so relevant. We hope the conversation will not only inspire reflection, but also provide practical insights that you can all take back to your organizations and communities. We are fortunate to be joined by a distinguished panel of experts representing perspectives from healthcare leadership, from ethics, technology, and policy. Our sincere thanks to Isiar Vaquero, Ali Habib, Dr. Robert Korom, Professor Kyoto Yoshinaga, and Gideon Williams for sharing their expertise and insights with us today. It's now my pleasure to introduce Isiar Vaquero, who will be moderating today's webinar. Isiar is a member of the EPIC Advisory Board and brings more than 25 years of experience in strategy, business development, and executive leadership. She's currently the Chief Strategy Officer and a member of the founding team of Abdali Hospital in Amman, Jordan. Prior to this, she served as Head of Strategy at Bupa, UK, was part of the founding team of Ibri Partners, one of Europe's fastest growing fintech companies, and launched 2 successful corporate ventures while at the Carbon Trust. Isiar began her career as a management consultant, working across Madrid, Sao Paulo, and London. With her extensive experience at the intersection of innovation, strategy, and healthcare, Isiar is exceptionally well placed to guide today's discussion. So without further ado, I'm delighted to hand over to Isiar to lead us through this important conversation. Isiar, over to you.
Thank you very much, Philippa, for this kind introduction. And thank you very much to the whole IFC Ethical Principles in Healthcare team for organizing this webinar on such an important and strategic topic for the sector. As we all know, AI has immense potential to revolutionize healthcare, with transformative applications already being implemented across providers, payers, medical equipment manufacturers, and pharmaceutical companies. But at the same time, as we are all facing in our all organizations, it brings significant challenges around governance, safety, accountability, equity, and privacy, among many others. Adding to that, we face a wide variation in regulation across geographies, together with the technical and structural challenges that are inherent to a fast-moving technology. Given that all of these, strong governance has become a top priority for every organization in this space. Today, we're going to discuss how some players are already adopting AI tools, the governance frameworks that the ecosystem is using to assess and monitor them, and we're going to discuss how different players are addressing key challenges. To guide us through this, we have 4 exceptional experts joining us. I will introduce them. First, we have Professor Kyoko Yoshinaga. She's a Project Associate Professor at Keio University's Graduate School of Media and Governance and an affiliate scholar at Georgetown Law's Institute for Technology, Law, and Policy. She specializes in the governance, law, policy, and ethics of emerging technologies, including artificial intelligence and robotics. She does this from comparative and international perspectives. During nearly 2 decades at Mitsubishi Research Institute, she supported Japanese government ministries in the development of ICT, media, and cybersecurity, and later led AI compliance and risk management in an AI development division. She currently serves as an Organization for Economic Cooperation and Development Global Partnership on Artificial Intelligence expert, and she's a member of Japan's Ministry of Economy, Trade and Industry Committee on AI Guideline for Business, and a member of the Digital Agency's Advanced AI Utilization Advisory Board. Next, we have William Williams. William is Deputy Director of AI for Health at PATH, where he leads a portfolio of initiatives applying generative and traditional AI approaches to improve global health, ranging from developing and evaluating AI-powered clinical decision support systems in low and medium-income countries to developing new evaluation methods for AI-enabled mental health products and strengthening the regulatory ecosystem. William previously led investments in AI for mental health at Wellcome and has experience at the intersection of AI and health from past roles in industry and academia. He holds a PhD in cognitive and computational neuroscience from University College London. Then we have Dr. Robert Coram. He is the Chief Medical Officer of Penda Health, a network of primary and urgent care centers in Nairobi, Kenya, serving more than 1,000 patients daily. Trained in internal medicine at Massachusetts General Hospital, he has led quality improvement and patient safety initiatives for over a decade in low-resource settings. At Penda, Dr. Coram has pioneered the integration of artificial intelligence into electronic medical records, designing and deploying clinical decision support systems that act as a real-time safety net for frontline clinicians. His work bridges clinical practice, technology, and regulatory considerations with a focus on ensuring AI tools do improve safety, reliability, and equity in healthcare delivery. And finally, we have Ali Habib. Ali is a senior digital health specialist in the Global Digital Health and AI team at the World Bank's Health Department. In this role, he provides technical assistance to World Bank country teams and clients on the planning, designing, budgeting, and implementation of digital health and AI in World Bank finance projects. He is closely engaged with responsible AI for health efforts at the World Bank. Further, Ali has led the development of knowledge products like the World Bank's Digital Health Blueprint Toolkit, aimed at helping countries design, cost out, and implement standards-based national-scale health information exchanges. He has 20 years of experience in the digital health space, including in the development, adaptation, and implementation of global digital public goods, supporting tuberculosis control, mental health, immunization, and maternal and child health in more than 20 countries. So thank you very much to all our panelists. As you can see, very impressive backgrounds, very international, very diverse, and I'm sure we're going to have an excellent conversation. We will start first with Professor Yoshinaga and William, who will give us a broad overview of the current state of AI applications in healthcare, what works, what doesn't, along with the general opportunities and challenges in the sector. We will then turn to Dr. Coram, who will share his experience implementing AI-enabled clinical decision support tools on the front lines. So will give us a very practical view. And then we'll finally close with Ali, who will offer a founder's perspective on how to assess these tools through a balanced risk assessment approach. We will then continue with the core part of this discussion, which is the panel discussion, where we will address your questions. You can put your questions through the panel, and we would like to thank already the ones that have already posted questions before the webinar. We will do our best to address them today. So with this context, we start with our panelists. Over to you, Professor Yoshinaga.
Thank you very much for having me and for your very kind introduction. I'm going to share my slide with you right now. Okay, can you see my slides? Perfect. Thank you. It's so exciting to see so many people joining us from different parts of the world, and thank you very much. Having supported policymaking and worked in risk management in an AI development division, I will approach AI in healthcare mainly from governance and regulatory perspective. So what do we mean by AI in healthcare? I think it is important to clarify this because AI can be used at many different levels. At the administrative level and operational level, AI can support scheduling, documentation, resource allocation, and hospital operations. At the patient-facing level, it can support telemedicine, remote monitoring, and communication with patients. At the clinical level, AI can support medical imaging, diagnosis, risk prediction, treatment decisions, and personalized medicine. And in research and development, AI is increasingly being used in areas such as drug discovery, clinical research, and genomic analysis. These applications are very different in terms of their potential impact and risk. An AI system used for administrative scheduling does not pose the same risks as an AI system that is used to support the diagnosis of cancer or recommend a treatment. So we should not treat all AI used in healthcare in the same way. The appropriate level of regulation and governance should depend on the function of the AI, its intended use, and its potential impact on patients. So opportunities and risks of AI in healthcare. I believe healthcare is one of the areas where AI has the greatest potential to benefit society. AI can not only improve the quality and efficiency of existing healthcare services, but also help us to detect diseases earlier, improve diagnosis and treatment, and potentially accelerate the discovery and development of new treatments and medicines. It can also help expand access to healthcare. This is particularly important in countries and regions where there are shortages of physicians or specialists. For example, combining AI with telemedicine may enable patients in remote areas to receive better access to medical expertise. In Japan, the government has identified 6 priority areas for the use of AI in healthcare, which are genomic medicine, diagnostic imaging support, diagnosis and treatment support, drug development, nursing care and dementia, and surgical support. At the same time, AI also creates risks and challenges. These include accuracy and reliability, bias and insufficiently representative data, privacy and health data governance, cybersecurity, lack of transparency, and over-reliance on AI. In countries and regions with limited healthcare resources, there may be additional challenges like unreliable internet connectivity, insufficient electricity supply, limited local health data, and limited support for local languages. So AI can help reduce healthcare disparities, but poorly designed or poorly governed AI can also reinforce or even widen existing disparities. Now, this brings me to the question of accountability. When something goes wrong, who is responsible? I think it is useful to distinguish between 2 different but closely related layers of regulation and accountability. The first layer concerns medical practice and clinical decision-making. The fundamental question here is who makes the clinical decision? AI can provide information, identify patterns, suggest possible diagnosis, or support treatment decisions. But AI should remain a support tool. Human healthcare professionals need to understand the limitations of the system, assess its output in the context of the individual patient, and make the final clinical decision. In Japan, Article 17 of the Medical Practitioners Act states that medical practice may only be performed by licensed physicians. And more specifically, in relation to AI, in December 2018, the Ministry of Health, Labor, and Welfare issued a notice clarifying the role of AI in medical practice. The notice states that AI should be regarded as a tool to support and improve the efficiency of physicians' decision-making in the clinical process, and that, at least for the time being, physicians remain the primary decision makers. In other words, even when AI is used in medical care, the physicians remain responsible for diagnosis and treatment and retains responsibility for the final clinical decision. Now, the second layer concerns the AI system itself. Here, the question is, how do we ensure that AI system itself is safe, effective, and performs as intended? Again, I think regulation should be proportionate to risk. Not all AI used in healthcare needs to be regulated as a medical device, but where AI performs a diagnostic function and an error could materially affect a patient's health or treatment, I believe it should be subject to appropriate medical device regulation. In Japan, AI-based software that meets the relevant criteria is regulated as Software as a Medical Device, or SAMD, under the Pharmaceuticals and Medical Device Act, or PMD Act. The framework considers both its contribution to diagnosis or treatment and the potential risk to human life and health if it fails. Now, these two layers are complementary. Physicians retain responsibility for the final clinical decisions, while developers or manufacturers have responsibilities for the safety and performance of the AI system. Now, these two layers provide an important regulatory foundation, but regulation alone is not enough. The World Health Organization has identified important regulatory considerations for AI in health in 2023. Including intended use, data quality, external validation, human intervention, cybersecurity, transparency, and monitoring throughout the life cycle. We therefore also need appropriate AI governance within healthcare organizations. First, organizations need clear roles and responsibilities. Who approves the use of AI? Who monitors it? Who responds when something goes wrong? Second, education and AI literacy. Healthcare professionals need to understand not only what AI can do, but also what it cannot do, including its limitations, bias, and the risks of over-reliance. Third, data governance, privacy, and cybersecurity need to be addressed throughout the life cycle of the system. And finally, continuous monitoring. AI performance may change as patient populations, data, clinical environments, or technologies change. Organizations therefore need to monitor performance, bias, incidents, and unexpected outcomes and adjust when necessary. Responsible AI governance therefore needs to cover the entire life cycle, from development and assessment to use, monitoring, review, and improvement. Now, let me conclude with 3 key takeaways. First, we should maximize the benefits of AI. AI has enormous potential to improve human health and well-being. Second, AI is a valuable tool, but at least for the foreseeable future, the final clinical decision should remain with the physician. And third, regulation and governance should be proportionate to risk. The greater the potential impact on patients, the stronger the safeguards should be. We should also continue to ask what risks may arise as AI is actually used, monitor how it performs in practice, and adjust our approach when necessary. In this way, I believe we can maximize the benefits of AI while ensuring that it is used safely and responsibly in healthcare. Lastly, I would like to thank Dr. Yosuke Takasaki for the very insightful conversation we had some weeks ago, which helped me greatly in thinking through some of these issues. Thank you very much. Muchas gracias, and ありがとうございました。
Thank you very much, Professor Yoshinaga. That's an excellent start of our conversation, a very helpful overview. I like your third takeaway specifically, the one about the balance, governance, and regulations. I can agree with you more, and that's probably some of the challenges we have. We'll have some specific questions for you in a minute, but I suggest we first hear another presentation from Whedon, and then we can do a little bit of a break in presentations, have some questions, and then we'll continue with the rest of the presentations. Over to you, Whedon.
Thank you very much, and thanks for having me. It's a pleasure to be here. I thought I would build on all the great content that we've just heard about and go one level deeper into some of the areas where we at Path see potential for AI in health and how that's contributed to our work. And I'll talk a bit about some of the challenges that we've encountered in deploying AI responsibly within those areas to try and have real positive impact on health. So the first place where we have done a fair amount of work is on AI for clinical decision support. And so, the general scheme here is that we want to be helping health workers to make better choices about what diagnosis to make, what treatment plan to go with, that kind of thing. How exactly you implement that kind of thing will look different in different contexts. It could be something that you would embed into a medical record system. It could be that you have a direct question and answer chatbot. And you'll need to fit the implementation to the specific cadre of health worker that you intend to support. The kind of advice that you might give to a community health worker would look quite different to the advice that you might give to a primary care physician. So we've done some work here benchmarking these kinds of tools to support community health workers in Rwanda, physicians in Kenya, and community health extension workers in Nigeria. We weren't the only people doing this work. We had a bunch of partners in each country, including Rob and his team at Penda Health. So I'll let Rob say more about the great work that they're doing over there. But as a field, we all quite like this particular use case because you keep a human in the loop. The health worker sits between the AI tool and the patient, which helps manage the risk of AI getting things wrong. But there is still onus on us and on tool developers to make sure that the guidance that is given aligns with local realities and the context, and also with the remit of the health worker. A second place where we've been doing some work, and it sort of is an extension of the decision support work, is in training. So our interest in training came from our work on decision support. The reason for that is that if you have people asking you for help and for support when managing patients, you naturally know something about where there are gaps in knowledge. So if I have a health worker that consistently asks for help in how to manage malaria, for example, then I know that there would be benefit in that particular person receiving some refresher training on malaria. So the question is, could you use AI to provide the next best piece of training for individual health workers? And also, generative AI opens up new opportunities for scalable training. So one thing that we and others are experimenting with is whether you can use large language models to provide good simulations as a safe space to practice. So if you can have a large language model take on the role of a patient with a particular health condition, then you give the health worker an opportunity to practice new skills in how they engage with that kind of patient. So we've been working with Digital Umuganda and the University of Global Health Equity in Kigali to deliver that kind of simulation-based training to support Rwandan community health workers to provide better care for mothers experiencing perinatal depression. That's work in progress. We'll have a feasibility trial over the next few months. But in general, AI for training has the same benefit as does decision support. You keep a human in the loop, and so risk remains relatively low. So, And that's true so long as the training that we're offering aligns with local guidelines. It's not to say that there isn't risk. We still need to make sure that the training that's provided is appropriate, but the presence of a human in the loop matters. So these are both ways in which we can support health workers, which is valuable and a thing that we should pursue. But because they focus on health workers, they don't make full use of the scale that AI offers. And for that, you need to remove the human from the loop. And to be clear, this isn't about replacement. There will always be a need for human delivered care, and that's the thing that we should prioritize. And AI is really helpful for helping healthcare workers to do more, receive better training, empower them within their roles. But there is also an opportunity here to fill gaps where human care can't keep up with demand. So, for one example, many millions of people now turn to generative AI for support with their mental health. The value there is clear. We have far too few psychologists and psychiatrists globally. This is true in high income contexts. It's more true in lower income contexts. But naturally, the risk then is greater. Without a human in the loop, we need robust ways of monitoring conversations to keep them safe. We can't just let AI loose to provide therapy for people all over the world. Therapy is difficult, complicated. We need to understand what's happening for people, how there are cultural differences in mental health. There's a whole load of things that need to happen to make sure this is safe, but there is also opportunity. So you have a range of different ways that you could deploy AI within healthcare. You could support health workers, which doesn't scale quite so far, but is no less valuable for that. Or you could offer support directly to patients, which does scale, but comes with more risk that needs to be managed appropriately. So however you're deploying AI, evaluation and evidence generation has to be a foundation to what you're doing. You need evidence that your AI models and your products are safe and effective. And we need to evaluate AI in two ways. So first, before we deploy anything, we need to be sure that we understand the capabilities of our models and products. To reach that point, we need to be designing tasks and evaluation frameworks that test whether models and products worked well in context. So, for example, on our work evaluating decision support systems in Rwanda, we worked with a few hundred community health workers who would submit questions to us on topics where they would like support as they were going about their daily practice. And so that gives us a really clear idea of the kinds of use cases in that particular context where AI could play a role. And then we tested a bunch of different AI models to see how they compared and whether they were actually able to provide care that was suitable for the context. So you need to do that kind of thing. Make sure that you build tasks that capture precisely the kind of thing that you're hoping AI can do. And then if you can generate solid evidence that your product works in principle, you can think about what to do after you've deployed it. And there things continue to be complicated. So the task shifts from understanding what your model or product can and cannot do to understanding the patient or the healthcare worker interacting with your product. You need to understand the user on the other side so that you can make sure that you aren't at risk of causing harm. This is difficult for reasons I'll get into on the next slide, but the challenge here is that if you reach scale, you will have many, many people interacting with your product, and those interactions all need to be monitored. And so, you might be looking for one exchange in many thousands that offers the wrong diagnosis or the wrong treatment plan, but you need to be able to find it with high accuracy if you're going to avoid causing harm. And so there are different models here, and what you do will depend on your confidence in your product. Before you have that confidence, near real-time human monitoring of AI output is necessary. But over time, as you gain that confidence, and as we build better automated methods, we could shift over to automated methods to help with that task of monitoring. So I'm going to pick out two quick reasons why evaluation, both pre and post deployment, is hard. And these are things that you would need to think about if ever you do deploy AI within health. So the first challenge is who's correct. So this plot here is from our benchmarking work in Rwanda. And you're looking at how human judges compare to AI judges when evaluating the quality of support offered to community health workers. The numbers that you can see tell you whether the AI judges were harsher or more lenient judges than humans. So Gemini's score of 6 means that Gemini was 6 times more likely than humans to offer a higher score for responses to community health worker queries. So Gemini just thought that everything was great. There was no issue. And so you can see that there's a spread here. Gemini is lenient, GPT-5 is harsh, Claude is somewhere in the middle. And that's all in comparison to human scores. But humans also disagree with one another. So there's a really tricky question here of how do you define what's the correct answer to a question? Humans disagree, LLMs disagree, and you need to be able to say this is the correct answer so that you know whether AI is doing well. The solution, I think, is to carefully design processes where you try to build consensus, but that itself is difficult. I won't get into it for the sake of time, but the general principle is to help human experts and potentially AI to deliberate and arrive at our sort of collective best guess for what's correct. Second, how do I know whether an exchange is harmful? So this is going back to that idea of looking for one exchange in 1,000 that risks causing harm. And the problem is that harm is deeply contextual. What's harmful for me might not be harmful for you. And we don't always know everything that we might want to know about the people using our products so that we can know what's harmful for them. And so this is basically a task of needing to make a best guess about what's driving a person's health problems so that we can make a best guess about what makes for a good or bad response to that particular person. And this is one place where having a human in the loop really helps. So you can rely on the health worker to be a barrier between AI getting something wrong and exposing a patient to that risk. But remember, that isn't free. It comes at the cost of lesser scale. And so we need to think through like what are some better methods there for how we can do that real-time monitoring. So to sum up, there are, of course, many different use cases of AI in health. One way to think about the range of possibilities is to think about, do they work with healthcare workers or do they go directly to patients? And those two setups come with different risk profiles. Robust evaluation and evidence generation is necessary for everything we do, and the burden of generating robust evidence and of doing that consistently post-deployment increases the more you try to do things autonomously, i.e. the further away a healthcare worker is from your product. And currently, I'd argue that there are problems that we as a field need to resolve so that we have both the evidence and the methods for generating it that we need. Thank you very much.
Thank you very much, William, again, for sharing your insights. Very interesting. I think the topic of the accuracy of tools and how to measure it is going to take a big part of our panel discussion later. So we have a few questions actually from the audience, and I would like to start just picking up on a couple of the topics that you have both touched on before we broaden it with a bigger panel. Professor Yoshinaga, you mentioned that AI has a great opportunity to unlock drug development, but there are barriers to achieve that. Can you give us a bit more insight about your thoughts on this?
Yes, so I see at least three major challenges. First, data scarcity. We may simply not have enough high quality or representative data, particularly for rare diseases or underrepresented populations. Traditionally, developing high-performing AI models has often required large data sets. At the same time, there is growing research on how to develop effective AI models with more limited data. So I think there is considerable potential there as well. Second, there's data fragmentation. Valuable data may exist, but they are often held separately by different hospitals, research institutions, pharmaceutical companies, or countries. So the problem is not always that data do not exist, but that they exist in separate silos. And third, data sharing issues. Even where relevant data exist, privacy, consent, interoperability, institutional rules, and commercial interests can make responsible data sharing difficult. In the pharmaceutical sector, for example, the data can also be an important commercial asset. So companies may understandably be reluctant to share valuable proprietary data. So I think good data governance should not simply be about restricting the use of health data. It should also enable appropriate and responsible data use and sharing. And without access to high quality and diverse data, we may not be able to fully realize the potential of AI for drug discovery and the development of new treatments. And I think this is an area where governments can play an important role, for example, by creating trusted frameworks and infrastructure that enable a responsible data sharing while protecting privacy and legitimate commercial interests.
Thank you. Thank you very much. Encouraging. We hope to see that. But for sure, having at least part of the solution through technology is certainly progress in the right direction. I'm going to ask a question to both of you, actually, because we have several questions on that from before and now as well. And you have both touched on it in your presentations, which is around the accountability. When an AI-assisted diagnostic or triage error leads to patient harm, where does the legal and ethical liability fall? On the clinician or the nurse on the bedside, the hospital, or the AI developer tool? Maybe you would like to start, Professor Yoshinaga, and then we'll move to Gideon.
Yes, so accountability is one of the fundamental questions in AI governance. When something goes wrong, who is responsible? The developer, the deployer, or the user? Here, I think it is important to distinguish between responsibility and legal liability. In healthcare, rather than a shared liability model, I would describe this as a shared responsibility framework involving three main actors: the AI developer or provider, the healthcare institutions, and the healthcare professional. The developer or provider is responsible for the AI system itself, including appropriate testing and validation, safety and performance, and communicating its intended use, limitations, and known risks. The healthcare institutions needs to assess whether the system is appropriate for its clinical environment, establish appropriate rules, provide training, and monitor its use. And the healthcare professional is responsible for using AI appropriately in clinical practice or considering the AI output together with the individual patient's circumstances. So shared responsibility does not necessarily mean shared liability. Legal liability will depend on the applicable law and the specific circumstances, what went wrong, who was in the position to prevent or control the risk, and whether each actor fulfilled their respective responsibilities. So the important thing is to clearly define who is responsible for what throughout the AI lifecycle.
Thank you, Professor Yoshinaga. And Gideon, we'd love to hear your perspective. One specific question the panel was asking now, the audience, is when there is conflict between what the AI tool says and what the nurse or the clinician thinks they should do, how would you address that? And if there is an error, who's accountable again? What's your experience on?
So, I mean, I think resolving conflict between humans and AI, I think intuitively the correct answer will always be to defer to the human clinical expert that's involved. At least until we get to a point where we have, really robust trust in AI systems that is backed by very strong evidence that we should defer to them. And I think we're not close to that now. And so I think for that particular problem, at least right now, I think the answer is reasonably straightforward. In practice, it might be harder where if you have individual healthcare workers who are unsure about what to do, they think this might be the answer, but the AI is telling them to do differently. And there, I think it's a case of, providing guidance for healthcare workers to how to interpret what AI is telling them and understand what errors AI can make so that they can make an informed judgment about, is there reason to think that I should change my mind? I think accountability generally is complicated. And I think my answer there would be that, perhaps frustratingly, it depends on the context. So I think, as I said in my run through of the slides, the risk picture is simpler when you have a healthcare worker in the loop. And that's partly because much of the responsibility for ultimately what happens and potentially even the liability can sit with the healthcare worker and the health system. But you still have thorny questions there of what if a tool advises a healthcare worker to do something inappropriate? And that's a place where this kind of conflict between healthcare worker and AI can come up. What if there's advice to make the wrong diagnosis, to prescribe the wrong drug? Does responsibility sit with a healthcare worker to spot the error, or does it sit with a tool developer to provide appropriate guidance? if you think about the direct-to-consumer option here, where there is no healthcare worker in the loop, off-label use there is really difficult. So OpenAI by now prohibit use of ChatGPT for health advice. It's in their terms of use. But people still do it, right? Like many people still go to ChatGPT for help with any number of different health conditions, with requests for mental health support. So there's a real question there around whether that um, term in the terms of service is sufficient, and whether a disclaimer from ChatGPT that, hey, I'm not meant to do this, is enough. And I think we don't have answers to those questions. And there aren't easy answers to any of these questions. And so I think the reality is that it's probably a thing that we need to resolve on a case-by-case basis. There are conversations that need to be had between healthcare systems, product developers, model developers. And I think that's the case at least until we have legal and regulatory frameworks that can provide better sort of normative standards and guidance for how to resolve these questions, which I'd argue currently we don't have.
Thank you very much for that perspective, William. And I think I completely agree with you. At the end, is very case by case basis, and generally speaking, lots of caution, as we are all seeing in the spectrum. So on that topic of accountability, frontline, direct to patients, I think it's a great time to make the introduction to continue the panel presentations with Dr. Corum, who will give us an overview of what happens in the frontline. Over to you, Dr. Corum.
Yes, thank you. And thanks to all the attendees today. It's really humbling to see so many people who are so interested in this topic from around the world, including many people that I can see from Kenya in the chat. So welcome. What I'd like to do is talk a little bit about how we've implemented AI at Penda. And I think the perspective that I can bring is as a frontline implementer who's faced sort of the very pragmatic questions, not thinking about this necessarily from a theory perspective, but what are the actual challenges we've faced and how have we resolved them? It's not to say that our resolution of those things is necessarily perfect, but I'm hoping to give you just a very real world picture of things. I want to start with why we actually use AI at Penda, because I think there's a lot of hype around AI and a lot of like excitement to use AI to show that you're tech forward. And the reason for us is really comes down to quality. In the setting where we are in Nairobi County, diagnostic accuracy and treatment adherence is actually very, very low. It's around 41, 43%. So that means that like almost half the time, patients in the primary care setting are not getting the local guideline recommended approaches to conditions. And that's something that we really felt we needed to fix. Harm is really common. So often this is medication related harm, but it could be harm because of a delayed diagnosis, or it could be a harm from maybe a procedure that was not indicated. And then finally, just from a value and money perspective, the per capita spending on health in Kenya is only about $80, which means that if half the time you're doing incorrect diagnostic and treatment advice, you're wasting 50% of the very little money that we have to try to improve people's health. So we really don't want to have any waste whatsoever at Penda. So in essence, we use AI because quality can't wait. Just for those of you who may not know much about Penda, we're a health delivery system. So we have 20 outpatient clinics, we have nationwide telemedicine, and we really, like I just said, we view AI as like a care quality intervention, not as like a kind of cool tool to use. And the way we've designed it is really for our frontline staff who are working under very real constraints. So our clinicians are clinical officers who are non-physician healthcare providers in Kenya, licensed to practice the full range of outpatient primary healthcare. And they're busy. They're seeing maybe 20 to 30 patients a day. So they need to work under like very real constraints. What I think is really helpful for a lot of people who may not have seen these tools is to get an idea of like, what can this look like? Not that Penda's version is the only version, but it's helpful to see what an AI decision support looks like. So I wanted to play this for you. This is our test environment, fake patient. I'm giving an example of a 27-year-old woman who has complaints that look like a yeast infection. And a really common error that's made here is people will order a urine test, as I'm showing here in the screen, rather than a vaginal swab. And so you can see that little blue shimmery icon means that it's sent an API call. And I'm going to pause it here for a second. It's sent an API call saying the clinician's trying to order a urine test. Given all of the above, that this is a 27-year-old woman with stable vital signs, a complaint of vaginal discharge, what do we think about that test? And what it says is that the urine analysis is not directly relevant to this primary complaint of white vaginal discharge. Probably it's a yeast infection, which is candidiasis, given the description. We think you should do a vaginal swab or KOH prep, and you can omit the urine analysis. So the way that we have set up our system is that the clinician always remains in charge. So they do need to acknowledge this to make it go away, but then they can do whatever they want. They can keep the urine test, they can ignore the advice. In this case, I'm going to show you how they remove the urine test, they add the vaginal swab test. And then when they do that, the system runs again, which you'll see that little blue shimmery icon. And now it's going to think like, is this, something that is correct? And you see that little green tick. We wanted to make it just a green tick because if you're doing the right thing, we want the technology to kind of just fade into the background. We don't want to force our clinicians to be reading AI outputs throughout their day. No one wants a job like that. So that's what it looks like when the AI thinks that everything is kind of in line. We have studied this clinical decision support tool very, very carefully. We've done a retrospective study, we've done a prospective RCT, we've done alignment analyses of the AI outputs. We've published many of these, which you can find online for free. Just to talk about some of the highlights from those studies, the retrospective study had almost 40,000 patients. We had 108 independent physician reviewers from around the globe, about a quarter of whom were from right here in Kenya. And what we found is significantly decreased errors across the board. So errors in taking history, errors in making a diagnosis, errors in the testing that we use, like the example I just showed, and then also treatment errors. So if you total all of that up, and you say, if we use this at Penda's current volumes, how many errors would we avert? We would avert more than 50,000 clinically significant errors per year. That is remarkable. And when you compare that to other decision support tools that typically act in a very narrow way, like maybe they only act on, let's say, preeclampsia, the benefit of this type of AI consult tool in primary care is that it acts across every single different type of patient condition, from malnutrition in children to emergency presentations to chronic illnesses. So I think a lot of times the ethical question for AI is framed as, is it ethical to use AI? And I think very soon, maybe even already, we should start asking at what point would it be unethical to not use these tools that are really shown to reduce errors. So I want to raise just like two questions that we've dealt with at Penda. One is, how should we handle scenarios where patient preferences conflict with medical best practices? And this actually came up in one of our clinician trainings that we do every quarter. This came up last quarter, where one of our clinicians was seeing a 30-year-old woman diagnosed with a routine UTI. And she said, for me, the only drugs that work are injections. I don't want pills. Okay, so then our clinician is thinking, well, the injection isn't that risky. I know it's not ideal, but let me order it. And then the AI is screaming like, oh no, this isn't the right thing. So it flags this as inappropriate, which is consistent with local guidelines. And so the question becomes like, do we make allowances within that AI tool to basically agree with patient preferences over what are considered local best practices? And I think the interesting thing about this is not necessarily where you come down on any specific issue, but it's that when you are building an AI tool, it forces implicit policy to become explicit. We, as a clinical governance team, need to literally write down in the instructions, when do we allow exceptions? Will we allow an injectable antibiotic when orals would do? And for us, the answer is yes, in this particular case. There are others, though, where let's say a parent was requesting a sedative for their crying baby at night. that obviously there the harm like to the child greatly outweighs like the benefit of the patient preferences. So that's something where we would say no. But the point is you need to codify it at the organization level. The second question, I like this kind of cartoon that basically the lawyer is sitting here saying, I'm just waiting to see which one you choose so I know who to sue. And I can see that it's come up in the chat and it was discussed in the last section as well. Who really holds the liability here? And I think the broader question for me ethically is how do we preserve dignity and autonomy for clinicians who are increasingly working with AI, right? Because we've heard from our clinicians at Penda that there is more and more of a sense of every decision you make is being watched, right? Every history that you're taking, what did you miss? Did you fail to get to a red flag question? Every test that you order, every diagnosis that you make, it's all tracked, and AI is able to see where someone may have made a mistake. And I think a lot of people are concerned about automation bias. One thing we've seen in our studies is that there are actually more errors in Penda due to failure to act on good advice than there are due to clinicians following bad AI advice. So I do think that we need to be thinking about this problem of automation bias and how do we hold the developers, including us as Penda, responsible. And I also think that disagreement doesn't automatically need to be treated as clinician negligence. We really need to understand the context before any blame is assigned. And I think we need to be really careful about how we're managing clinicians here. And I think for Penda, the future that we view is that clinicians are really valued for their judgment, their empathy, and the connection they have with patients. They're not valued because they have this like flawless recall under very busy circumstances, which is, I think, how doctors used to be kind of mainly valued. So I'll just close by saying I think AI enables this like really unprecedented scale, period. And if we do good work with that, we can scale great positive impact. But we also need to understand that even small biases and mistakes in what we're doing can also scale harm. Thanks.
Thank you very much, Dr. Coram. Very, very impressive results. I'm sure everybody would agree with that, and definitely for your context. And thank you also for sharing some of the, more frontline perspective and clinician perspective on this topic. We will move finally to Ali to close the panelist sessions before we start opening the floor for more questions. Thank you very much to everybody who is already submitting questions. Ali, over to you.
Thank you. Just confirming you can see my screen.
Yes, we can.
Ali. Okay, thank you. I'll proceed. So I think that Dr. Coram's presentation set mine up very nicely, especially that last line where we can talk about not to focus on the negative, right? But the fact that organizations like the World Bank are all about scale. And so how do we figure out what it is that works, and how do we protect patients from mistakes that we make in scaling things that do have problems, and how do we kind of think about approaching that, and what to invest in, and what to sort of, when we have conversations with countries that we support, what to encourage them to think about when they're thinking about, should I use AI? Should I not use AI? What tool should I use? How do I know it works? How do I know what the harm is? And I'll preface it by saying there are a lot more questions than answers, but this is thinking about how we can approach frameworks for responsible AI health. I don't claim to have a framework in my pocket or an answer readily available. But to contextualize that, and kind of Dr. Yoshinaga kind of addressed some of this, when we think about challenges in low and middle income countries with health AI, there are challenges with infrastructure. There are challenges with cultural fit. There's missing, absent regulation. There are capacity gaps. This is not new to any of us, but I'm kind of calling it out to contextualize where we're going from here. There are questions about affordability and licensing. There are questions about data. Is it relevant? Is it correct? Is it something I should be training my algorithms on? Is it relevant to my context? What happens when something goes wrong? Is my health workforce equipped to use it, to understand how to use it? And then, of course, gaps on infrastructure like connectivity, cloud computing. None of this is news to anyone in the room here today, but just kind of calling it out. And we do have work happening, and it's great to have Dr. Coram and Gwydion on, because Path and of course Dr. Coram's work has contributed to some of this analysis. The reason for presenting this slide is to indicate that when we think about scale as a funder, right? When we think about funding, what to fund, what not to fund, the question, of course, it's important for things to work. It's important for an algorithm to be at least as good as a physician if it's doing clinical decision support. It's important for an AI an X-ray tool to be as good as radiologists or better. That's great. That's fantastic. But it goes beyond that, right? It goes to being used in the settings where these tools will be applied. Does it work there? If my chatbot or my clinical decision support tool is something my doctors are not using, don't know how to use, don't trust, are using incorrectly, my patients don't want to use it, then it doesn't matter how good that tool is because it's not working in the environment. I mean, it doesn't matter, it's a strong word, but kind of it's not doing what you expect it to do. And the question becomes, should I scale this or should I not? So from the perspective of someone funding this for scale, the question goes to, have health outcomes improved as a result of these tools being used? And there are cases where they have, there are cases where perhaps we don't know that they have. And so as Gwydion said, we don't know yet. We don't have all the evidence, and it's important to kind of understand how we can approach getting that. And it's great to see work like this happening, where we're starting to see, evidence come out. But I think at the end of the day, what's important is it actually making a change to health outcomes? And if it is, fantastic. If it's not, then we have to keep asking questions. And this takes us to, when we think about how do we approach kind of what to fund, what not to fund, and others outside the World Bank as well are arriving at this kind of notion of a risk-based framework for health AI. When you approach it from the perspective of the risk to a patient or the risk to a user, and you might think that that's a very, negative way of looking at it. Like, why do we not look at it from the perspective of how useful could this be? But I think that that's because we don't have all the evidence today. The burden shifts a little bit more towards looking at it from a risk perspective. And that's not necessarily a bad thing, because if you have frameworks that are using risk, then for one, your low risk tools can start to move faster. So we've been seeing, for example, AI enabled chest x-rays have been used for the last decade. Before AI was cool, right? We had AI enabled chest x-ray for tuberculosis. It was being used in the field, it was working. You were potentially saving money by using it. And so there you have this legacy of evidence and a lower risk. In the same way, if you are screening somebody for a disease versus prescribing treatment, again, the risk profile is different. And so this is what Whitney was because AI in health is not a monolith. AI in health has applications and use cases. So we can't look at this from this works for all of health AI. You have to look at the use case in question and treat it on merit. And it just allows things that are low risk to move faster, and it allows you to focus on the higher risk areas to look for more evidence or develop the frameworks to look for more evidence. That's useful. It also surfaces risk earlier. And I'll give an example of a project where we are doing this in the next slide. But essentially, it's allowing us to focus our resources and efforts on the higher risk use cases. It also makes it easier for organizations like ours actually to support procurement, very, very frankly, right? Like if you are doing scale up procurement, what can you procure? What can you not procure? And having a risk profile available to you to kind of differentiate between different use cases and different applications makes that very pragmatic thing much easier as well. And frankly speaking, as a funder, we are a development bank, there is the question of liability and questions being asked about why would an organization fund this? And so there is, to be very honest, that also factors into this kind of risk-based approach to doing this, to be very, very honest. So it may be perceived as something that's very negative or a very kind of pessimistic view of the technology, but it actually can help move things along much faster if you take that approach to assessing it. And one example where we're actually doing this, we're financing this in the South Pacific, is the Pacific Healthy Islands Transformation Project, where the World Bank is financing the development of a multi-channel AI application that is being used, that will be used when it's developed to support frontline healthcare workers to screen for NCDs. And so this is going to be multi-channel, so it gets around infrastructure limitations by being available through SMS, phone call, smartphone app, trained on local guidelines. And the challenge with implementing this in these countries, and the specific countries I'm referring to here are Fiji, Tuvalu, Tonga, and Kiribati. So this is the South Pacific. There are missing regulatory frameworks. And in that context, you also want to be able to implement. You don't want to be hooked on waiting for AI regulation to be in place, because that can take several years. And so how do we support countries to move despite that constraint? And so the approach the World Bank takes is that the country basically, when they receive the financing, they sign on to developing a risk mitigation framework based on a pre-deployment assessment. And then regulation can be developed in parallel with that, where it happens. But for that specific application to be used, even before development can begin, there is a risk assessment done, and there is a risk mitigation framework put in place, which coordinates with our legal team to put in place the frameworks to assess risk and see how you would deal with that risk. And then things proceed, right? So it's not like, this is exactly kind of what I'm saying, that the risk approach does not need to be, it doesn't get in the way necessarily. It is an additional step. But in the Pacific, what's happening is they're creating a framework, and that framework is going to be used for other application use cases as well. And the government's going to be trained to use it. So they'll be able to do, because it doesn't end with one application, right? You could risk, you have AI algorithms drifting, you have all kinds of changes, you could have changes in use cases. And so to be able to reapply that framework and reassess and remitigate as needed is some of what we're trying to support in the Pacific, just to give a sense of where this is actually being used. And that's it. That was a very short presentation. I want to give us more time for discussion. And thank you for all the panelists who came before to set the stage for this. Over.
Thank you. Thank you very much, Ali, and thank you very much to all the panelists. So I would like now to open the floor. We have a lot of very interesting questions, and I would like to start probably with a question for all four of you, which seems to be the most recurrent question from what I can see so far in different shapes and forms. A lot of the audience is interested in, can you recommend standard approaches, toolkits, frameworks that can help organizations decide where do they get in, what tools to buy, how can actually they choose the right tools? So perhaps we start with you, Ali, since you touch a little bit on your work on the World Bank precisely on that, and then we'll move to the others.
Sure. So, I mean, like I said in my presentation, I don't have the solution in my pocket. But I think that as organizations, and in our case, countries, think about approaching, what tool should I use? What is safe? What is not safe? I mean, this sounds very obvious, but the first question you should be asking is, do I need AI to address this problem? That to me is question zero, which, not enough people ask, frankly. And so that's one, that's the first question. But secondly, then, you look at the application and you kind of approach this, like I was saying, from this perspective of risk. And we have some internal guidance on this for our teams that is not currently available outside. I don't know if it will be, but when we approach it, kind of what do we think about, and when do I, ring the alarm bell and call the legal team for help? So that's kind of how, at a high level, we're approaching it. Like I said, I don't have a step-by-step framework in my pocket, but that's one way to approach it. Yeah, over.
Thank you, Ali. I agree with you fully. I think having a risk approach perspective is definitely the first step, and is very consistent with the regulations in the EU, for example, which very much all the act around AI is based on a good risk assessment. Could we hear perhaps from Gideon as well, since you've done so much work on the more technical statistical side of things? So what's your view about what tools, frameworks could you recommend for the audience that they can use?
Sure. So I think to expand on what I was saying earlier around it's hard to know what it means for an answer to be correct and to define the right answer to a particular question. If you think about that at a fairly sort of basic practical level, there are, I think, choices that seem boring when you first encounter them, but are really consequential for what you then have as the data that you can use to decide which model is best, what product to use, and so on. And one of those questions is around how are you scoring? So this is a mistake we've made in the past where we defaulted to using 5-point Likert scoring, which is where I would ask a question like, does this response include any irrelevant information? And you would ask for a response on a 5-point scale, 1 being there's no irrelevant information, 5 being there's loads, and then you have scores in between. And that might feel like, yeah, that's a fine way of doing this. Let's just go with that and we will proceed. But it has problems. So I personally, by now, don't like 5-point Likert scores. 1 and 2 are basically the same. 4 and 5 are also basically the same. And 3 is either I don't know or I don't care. And so if you build your whole evaluation framework around that, you pay for human experts to evaluate your product, and then you reach the end of your assessment period and you have a bunch of scores that don't really tell you much. Or if they do, they don't tell you as much as they could. And so I think thinking carefully about that kind of decision is important. And to give some ideas for other frameworks that you could use to think about this kind of evaluation, you could collapse this to just be a binary thing. So is this response good in this way, yes or no? This is what OpenAI did with their health benchmark, where they had many clinicians develop these long rubrics that were applied to specific questions. So they would have one question and they would ask human experts, can you list all of the things that need to be present in an answer to this question for that answer to be good? And so you would then say yes or no to each of those things as being present or absent, and that's the thing that tells you whether whether any response to that question is good. That gets you a bit closer to defining goodness in a way that's tractable. And so that's one way that you can go about this. It's a bit more labor intensive, but at least you're defining precisely what you mean by good or bad. And then one other thing I'll say is I think we as a field could think about using pairwise contrasts a bit more. So this is where I would give the option of 2 possible responses to the same question, and I ask a human expert which is best. And in general, it's easier to tell the difference between 2 things in terms of how much I prefer them and how good they are than it is to say how good this one thing is. If I ask you, do you prefer apples or bananas, then you will know. But if I ask you, how much do you like apples, then that's like super ethereal and hard to get a purchase on. And so if you have these like pairwise contrasts that you ask for at scale, you can then use that for some measure of goodness that is more reliable. And you see model providers doing this. You may have had it where you ask ChatGPT a question and it would give you 2 possible answers and you would have to pick which one is best. That's OpenAI putting this into practice so that they have this like proxy signal for what do the users want. We could experiment a bit with that as well in our domain to figure out better ways of deciding between models and products. So yeah, my advice there would be think carefully about the evaluation framework you use and the implications that has for what you can then say with the evidence that you will generate using it.
Thank you very much, Gideon, for this exhaustive answer. Professor Yoshinaga, perhaps you can give us a little bit of your experience, also looking at more pragmatic, perhaps guidelines on procurement or that business use. Go ahead.
Yes, so let me give you one example from Japan. Japan Digital Agency has developed guidelines for the procurement and use of generative AI by government ministries and agencies. One particularly useful element is a high risk assessment sheet with a risk assessment flowchart, Before introducing an AI system, the organization assesses the intended use and asks whether errors in the AI output could have a significant impact, for example, on people's rights, safety, life, or health. And depending on the answers, the use case may be identified as potentially high risk and subject to greater scrutiny. The guidelines also provide practical procurement and contract checklists. So rather than simply saying use AI or do not use AI, they provide a structured process for assessing the risk before procurement and deployment. Of course, these guidelines were developed for public administration, not healthcare. But I think a similar risk assessment approach could be very useful for healthcare organizations as well. In fact, in healthcare, this distinction may be even more important because the consequences of an error can range from very minor to potentially serious harm in diagnosis. Japan also has the AI guidelines for business, which provides broader principles and practical guidance for organizations developing, providing, and using AI. And finally, from my own experience working in an AI development division, having a checklist is not enough. Organizations need to establish their own AI policy, translate it into internal rules and procedures, clearly allocate responsibilities, and provide training and education. Then after deployment, they need continuous monitoring. So for me, responsible AI governance is a continuous risk-based cycle. Assess, procure, deploy, monitor, review, and improve.
Yes, I completely agree with that as well. And very helpful to have those practical tools from Japan. I believe there are similar tools in other countries as well. And again, it's quite country specific. Professor Coram, Dr. Coram, would you like to give us a little bit of perspective from the physician point of view? We have a question related to the above, but really thinking more about from a clinician perspective, what are your non-negotiables when you choose a tool?
Yeah. I think when you're implementing a new AI tool, there's three things that I would want to make all of you conversant with that I think are really, really critical. Two of them happen before you deploy the tool. So the first is called a golden set. So you basically come up with a bunch of scenarios that you are likely to see in your deployment. And you, before doing anything with AI, you just have your clinical or your technical team think about how do I want the AI to respond? So in the example that I showed in that kind of screen cap, it's like if someone has vaginal discharge as a chief complaint and urine analysis is selected as the only test, I expect the AI to say, no, don't do the urine test, do this other test. And then what I do is I create very specific inputs that map exactly to what I use at Penda. So that means like the same language that we use, the same formatting that we use inside of our EMR, the same acronyms that we use. So not taking an idealized case, but taking like a very real world case. And then I run it through my AI tool and I see what I get. And sometimes it might give me a little green tick. And then I say, nope, that's not working. That's not right. So I can't deploy this yet. And then I need to go back to the prompt. I need to adjust it until I'm getting a very high level of performance across all of those golden set cases. And for Penda, the number of golden set cases that we have exceeds 100. So it's a lot of very specific performance characteristics we're trying to get to. The second thing is red teaming, where you intentionally try to break the system. So you can give different clinicians, you can say, try to make the system give you a bad result. And then they'll play with it and they'll think of all different scenarios that you haven't thought of. And then they'll be like, oh, Rob, look what it gave me. It gave me this bad result. And then we're like, ooh, we got to go back and we have to change that. So that red teaming is a really, really important part. And that's something that I also do for other people's tools because I find it fun to try to like poke holes in it. And then the last thing is what we call post-deployment monitoring. And I would say in many ways, that's actually the most essential thing because there's only so many things you can think of in the pre-deployment sandbox testing. You really need to get it out into the world with the messiness of real data, the messiness of how clinicians will end up using the tool. And then you need to watch for all the problems. We have learned probably 10 times more in our post-deployment monitoring than we did in either of the first two things. So you have to do them, the first two things, but what you really need is like a good loop closure after you deploy.
Thank you. Thank you very much. And yes, it's interesting to always beat the machine with proper judgment. I'm going to move to another topic that we have several questions around as well, which is you have touched into it, both you, actually, Dr. Coram, and also Gideon, which is the topic of bias. And when you are either buying a tool from the market or assessing it, or when you're developing your own tools, how can you make sure that the algorithm is built in the right way to ensure that there is not bias that is negative for your patient community? We can start with you, Dr. Coram.
Oh, great. Yeah, I think like algorithmic bias is a really big concern with rolling these things out because, as I said, everything that you do gets magnified. I think that there's types of bias, like someone I see in the chat brought up this like Optum example from the US where AI was systematically projecting like lower cash spends for Black patients in the US. I think when it comes to a large language model decision support, like what we've had at Pendo, we've had some examples of bias where it's like sort of much more mundane. So an example that comes up is a clinician gave a brand name cough syrup called Zefcolin, and the model thought, Zefcolin, that sounds like a third generation cephalosporin antibiotic. So I'm going to give a red alert saying, why are you giving this antibiotic to this patient? And the clinician was like, I'm not. This is just what a cough syrup is called here. So that's a type of bias where it doesn't know all the brand names of medicines from around the world. So it's a pretty easy fix, and it's not terribly consequential because the clinician can just ignore it and then raise it to us. We correct it, and then it doesn't make that mistake again. But I would say then the last bit of bias that I find extremely problematic that we can't solve just with large language models is that there's simply not enough like medical research in all different parts of the world. So for example, like, do we know the cardiovascular risk assessment for patients in Kenya? We haven't done a big 30-year trial across tens of thousands of people with lots and lots of different data points. So we actually don't know. It's just a gap in medical knowledge. And that's a more foundational gap that we really need to address because until then, it's not so much an LLM bias. It's just that the LLM is like, I don't know what to do here. So the only thing I have to base this on is sort of consensus recommendations. So I guess I would make a big push that we should be doing a lot more localized medical research.
And maybe I can add onto that. So I think one kind of bias that we sometimes worry at PATH is at risk of sort of flying under the radar is bias in the LLM judges that we use. So you've got the development of the products themselves, but then the post-deployment monitoring piece that, as Rob was saying, is so critical, often relies on using LLM judges. Not always. Many groups will also have human clinicians perform at least some part of the post-deployment evaluation chunk. But when you have an AI product deployed at scale, you need a similarly scalable way of monitoring the conversations that are happening with it. And so we have LLM judges come in to help with that problem. As I mentioned on my slides, we did some research on this to look at how different LLMs perform in how well they can do some of this LLM judging work. And so we had LLM judges assess the quality of responses to requests for decision support from Rwandan community health workers. And our LLM judges evaluated those responses on 11 dimensions. One of those dimensions was the potential that any one response carried any demographic bias. And one of the starkest findings that we had from our research was that every single LLM judge almost gave a perfect score of 5 out of 5 for virtually every response. So they identified no bias in any of the responses that they evaluated. we had local clinicians perform the same evaluation and they did not agree. They thought that there was bias in some of the questions. It just wasn't a thing that the LLM judges that we were using were able to spot. There are some issues with the research. Like I think we would have done it differently if we were to do it again. But the basic point there is that using LLM judges to evaluate the quality of other LLMs that we're not sure we can trust, there's a level of irony there and like a circularity in the system that we need to be aware of and resolve. And if we don't, I think we're at risk of having products that are misaligned LLMs all the way down, basically. So essentially, we just need a concerted effort to, make sure that the LLM judges that we're using are themselves not biased and are able to detect bias where it comes up in the products that we're using.
Thank you, Guido. I think it's definitely tricky to be using AI who can make mistakes to assess AI. For those of us who are not statisticians and not very techy, I was wondering, Ali, whether we can share perhaps your experience in the World Bank to offer some advice about some pragmatic questions or some pragmatic approaches that people, users who are not very technically savvy can still use to see or to test for bias. Can you give us your perspective from your experience in the World Bank?
Yeah, I mean, I think that at a high level, if you're, say, a minister of health thinking about should I deploy this in my country or not, then three sorts of questions come to mind. One would be finding out if the tool actually was tested on your own population or a similar population, right? So it doesn't always have to be the same. There's a lot of similarity as well. So that's one sort of question that you want to be asking. Because we've seen examples where tools that worked really well in one country actually did not work well. There's a very good one about chest X-rays from Mongolia and Japan, and those not being, the tool could not use them effectively because the people are sized differently or have different, so it wasn't working. Just as one basic example. So that's one question to ask. Another one is there a way for someone to flag that there is a problem? And by someone, I mean a human someone in this instance, right? So if there is a problem, can someone report that? And is there a process for that to be looked at? And three, how is there a way to keep monitoring this over time? Or rather, how do I keep monitoring this over time? Because we won't always see bias on day one, right? Bias only comes out when you have a situation where you have somebody from an underserved population, for example, or a different ethnicity, or some difference from populations the tool actually was tested on. And so how do I keep track of this over time? And where I find issues, what can I do about them? Would be sort of three questions I would say that someone sitting in, say, a Ministry of Health who doesn't understand the internals of how LLMs work would want to pose to the person they're procuring from or their team to kind of address. Yeah, over.
Perfect. Thank you very much for that, Ali. That's very, very pragmatic. I see, looking an eye on the watch, and we have a few minutes left, and we have a lot of questions. So I would like to reassure the audience that we're not going to be able to address all the questions now, but we commit to actually sharing our answers after this panel. So there are a couple of questions that I would like to squeeze in, if we can. One is around consent forms. A lot of people have in their minds that, how aware does the patient need to be about the use of AI tools? And there are two perspectives here. One is when the AI tool is being used in some form in the delivery of care, and the other aspect is when it's being used in terms of their data being used to inform the development of tools. So perhaps we'll get answers from Professor Yoshinaga. Perhaps we move to then Dr. Korom to have two different views very quickly on this.
Okay, so thank you very much for the great question. I think we need to distinguish between these two issues. First, informing patients that AI is being used in their care, and second, using their data to develop and improve AI systems. For example, if an AI scribe is processing a confidential conversation, patients should know that it is being used, what happens to their data, and whether they have a choice not to use it. For diagnostic AI, the situation may be somewhat different. If AI is incorporated into an approved medical device, and it's simply one of the tools that the physicians uses in reaching a diagnosis, I don't necessarily think we need a completely separate and lengthy AI consent process every time. But if the use of AI materially affects the patient's care or introduces particular risks, those risks and limitations should be appropriately explained just as they would be for other medical technologies. And the second question is the use of patient data to develop, train, or improve the AI system. And I think we need to distinguish this from using the AI to provide care to that particular patient. If existing or newly collected patient data are going to be used to train, customize, or continuously improve an AI system, that use must comply with the applicable data protection law and health data laws. Patients should be appropriately informed about what data are being used, for what purpose, whether they will be shared with third parties, how long they will be retained, and what safeguards are in place, and whether explicit consent is legally required will depend on the jurisdiction and the particular purpose and legal basis for processing. Developers and providers also have an important responsibility here. They need to clearly communicate to healthcare organizations the known risks and limitations of the system, how patient data are processed, and whether those data are subsequently used for training or improving the model. So the key is meaningful transparency and an appropriate level of consent, depending on how AI and patient data are being used.
Perfect. That makes a lot of sense. So I think we have only 4 minutes left. I have the IFC team asking me to finish on time. So Dr. Koram, we're not going to get your answer on this. I think Professor Yoshinaga was actually quite exhaustive. What I would like to do instead is just in 30 seconds to a minute each, if you had to give one advice to the audience that is currently starting in their AI journey, what would it be? What's the first thing you think they should be thinking of? So we can start with maybe Professor Yoshinaga, since you're on the screen.
Okay, so start with the benefits, but always think about the risks. Don't introduce AI simply because it's available. Think carefully about what you want to achieve with it and what risks may arise. Thank you.
Perfect. Dr. Koram, would you like to go next?
Yeah, sure. I think, the thing I would leave you with is do your due diligence in terms of your golden sets, your red teaming, your sandbox, but don't believe that that will make your AI tool perfect. You have to get it into production and you have to learn in post-production.
So learn as you go. The job is never finished. Thank you, Dr.
Yes.
Koram. William, would you like to go next?
Sure, thank you. I think at risk of sounding like a broken record, think very, very carefully about what it means for AI to get something right or wrong. It's deceptively hard to answer those kinds of questions. So give yourself more time than you think you will need and prepare to iterate on your definitions.
Yeah, definitely iterative approach again, completely agree. And finally, Ali, would you like to give us your advice?
Yeah, I mean, I think be very clear, and maybe I'm sounding like a broken record too, but be very clear about what it is you want to achieve with the tool. There's a real risk of people using AI because AI is there, and that's not a good enough reason. So just pick the right tool for the job, and do your research on that one. Over.
Thank you. Thank you very much. Excellent advice. And I would add as well for people to think about governance. Just think about your framework. What is your criteria, your structures to making decisions? And very important, as mentioned today, to continuous learning. The other one is take risks, measure risks, because obviously we're in healthcare, but in terms of learning, and give yourself that opportunity. So I think with that, we're just on time. I would just like to thank you very much to our panelists for your insights and for this thought-provoking discussion. there are so many questions and so many insights, and I think we could have many more hours of this type of conversations. I would like to thank the audience again for your engagement and for your questions. And as I said, we will try to answer them after the webinar as well. So I hope this will be the beginning for a forum for further exchange as we continue progressing our learning on adoption of AI tools. Thank you very much. And I think, Philippa, you wanted to give some final remarks.
Thank you, Isiar. No, it's just a huge thank you to everybody. Isiar, thank you for moderating this session so perfectly. Thank you to all the amazing panelists for sharing your insights, your experiences. I think there are so many takeaways. I think just one thing that's come through very clearly is that responsible use of AI isn't something just one group can do alone. It's going to take all of us, healthcare leaders, technology developers, policymakers, and others to make sure AI, truly serves people and helps strengthen our healthcare systems. And thank you to all our participants today. We've actually had a record attendance, so thank you. The questions have been really great. As Isiar mentioned, for the ones we didn't get to today, we will follow up and share responses later. And lastly, we invite your organizations to join us as EPIC signatories if you haven't already, so you can continue to be part of these conversations and make use of all the resources EPIC has on offer. So thank you once again to everyone for being part of this really important conversation. Thank you.